Good morning, everybody. How is everyone this morning? Here, right? Okay. This is my first time at this conference, so thank you for having me, first of all. Secondly, this is pretty interactive. If you have questions along the way, feel free to ask. Feel free to raise your hand, interrupt. And I'm going to try to leave some time at the end for questions also, but again, feel free to join in as we go along. So my talk is really looking at obstructive airways as kind of a whole and not just on COPD, because as respiratory therapists, I'm sure you all have been called into the room before because a patient is quote unquote wheezing. And when you come in the room, you are the first people really to assess patients in that capacity. And I think it'd be good to have a broad differential when you walk into the room and say, hey, you know what, I don't think this is just COPD. I think there's something more going on with this patient. So we're going to kind of kick into that. So looking at the overall agenda, which I think is up there. Okay, coming up. We're going to do an anatomic breakdown of obstructive airways. Then we're going to kind of go into the different types of obstruction: laryngeal, tracheal, bronchial, and then widespread airway obstruction. We are going to also touch on COPD, but I'm saving the best for last. So if we look at the actual anatomic breakdown of obstructive airways, I'm sure we're all familiar with the tracheobronchial tree. If we kind of take it piece by piece, where could the obstructions occur? Anatomically, what does that cause? And what types of disease processes can occur to create that kind of anatomical obstruction or physiological obstruction? So the larynx, which is cephalad to the trachea there, which you're not able to see. If there is obstruction there, you're going to hear very localized wheeze and or stridor. I'm sure you're familiar with hearing that with patients who have vocal cord dysfunction or have just been extubated. You can see this besides vocal cord dysfunction with tumors also. I'm going to do a quick overview and then we're going to dive into each one. Tracheal obstruction, you're going to hear more a stridor. This is an extrinsic compression, sometimes from the thyroid, from the lymph nodes, sometimes for lesions within the wall, or the cartilage itself is an issue. We're talking about tracheomalacia, relapsing polychondritis. Bronchial obstruction is, again, a localized wheeze, not really as diffuse. This is, again, like an extrinsic compression within the lymph nodes surrounding the bronchi or tumor, or lesions within the wall, such as foreign bodies or tumors. And then widespread airway obstruction, this is kind of your classic. These are your classic diffuse wheezing that you're hearing, and this is going to be asthma, COPD, bronchiolitis, pulmonary edema, and a couple more that we're going to deep dive into. So let's talk about laryngeal obstruction. Again, we're going to hear wheezing and stridor for that. So if we think about the larynx itself, and the focus is on the vocal cords, then with vocal cord dysfunction, there's going to be an abnormal narrowing of the larynx. This will lead to dyspnea, hoarseness, wheezing, cough, throat clearing. Can occur in the most obscure situations: high intensity exercise, just irritant exposure, postnasal drip, reflux. These are just a few. The actual therapy is one of my favorite things to treat because it's really speech and voice therapy. It is breathing exercises, cough suppression, throat clearing techniques, and voice therapy. There is a distinct difference between vocal cord dysfunction and asthma. And people will confuse the two, myself included. With vocal cord dysfunction, you're going to see the little kid on the left-hand side of the screen. There's a high-pitched sound. They have like a grating voice. They are struggling with inhalation. And there's a tightness in throat. And just like this kid, they're going to be pointing their throat. Patients usually point to exactly where the problem is. With asthma, the breathing sounds are like wheezing. They're struggling with exhalation at that point, and there's a tightness in their chest, and they'll point to it. There's a difference. The concern with vocal cord dysfunction, this is an acute onset. But if you can find the cause and you can treat it, it is a rapid recovery within seconds to minutes. Asthma can be acute. More situations, it's a little bit of gradual and then becomes acute, and then takes time for recovery also. I've seen this in patients who get intubated. Patients come in, they're like, I cannot breathe, they're struggling, they're stridorous, they cannot talk. I mean, they are in respiratory distress. You intubate them within seconds. They look better. They're not just oxygenating better. They're able to talk around the tube. And you're like, wow, that was too fast. That wouldn't happen with asthma or anything else. And then you extubate them, and it comes right back. And you reintubate them. So you really have to focus on what is this anxiety that's causing it? Is there any kind of irritation that they've been exposed to? Is it just purely reflux that's causing this? And once you actually find the cause, you treat it, it is a complete cure. And you go through breathing exercises and teach them basically what to do in situations when they're having high anxiety stress, or where they're having high anxiety about or high level of exercise. And it's amazing. They never get intubated again. I have seen patients get trached for this. So I think it's really important to identify it. And since you are first line, you're going to be the ones walking in the room saying, I don't think this is asthma. There's something more going on with this patient. This is not making sense. So that's really kind of the crux of larynx obstruction, laryngeal obstruction. Let's go to tracheal obstruction. So in tracheal obstruction, we're talking about just the trachea now. If you look in the middle diagram, you can see what the normal airway looks like, the top part, with inhalation and exhalation. If you end up having any kind of obstruction or kind of pathological abnormality of the trachea, one of the common things we'll see is tracheomalacia. And when they inhale, the actual cartilage is incredibly floppy and it flattens out. When they exhale, you sometimes don't even see an airway when they're exhaling. It is that flat. It's called like a little sphere or like crescent moon. There's different terminology that people use. Basically, you're not really seeing an airway at all. There's different types. Type 1 is congenital. This is with children, usually identified pretty early on. Type 2 is extrinsic defects, abnormal vascular rings, and type 3 is acquired, which can be seen in relapsing polychondritis. This can also occur with prolonged intubation, which is why we push our patients and family members to make a decision within 7 to 10 days if we're going to extubate or move to an actual trach. Chronic trachs can lead to this, repeat infections, bronchitis, goiters, tumors. Unfortunately, if this occurs, this is only a surgical fix. There's nothing else that can be done once you have tracheomalacia. So there are stents that can be placed in. It used to be just by the thoracic surgeons, but now the interventional pulmonologists, not myself, but my colleagues, Dr. Ventura and Dr. Garwood Centennial, are the main ones who actually focus on tracheomalacia. And there's a stent that can be created, and it's amazing. You can use a 3D printer to print out the actual stent for your airway based on the 3D of what the CAT scan shows. It's amazing. They print it out, and they literally place it with the bronch. So you can see kind of sequentially on the pictures, tracheomalacia, they're putting the stent via the larynx, they position it, they inflate it, they kind of deploy it, and that's the stent. And this is really for tracheomalacia, or if there's tracheal stenosis. Now, if there's complete floppiness of the airways, and there's no way a stent can hold, you call in the thoracic surgeon. There's very few limited options. This is why, again, I really push patients and family members to make a decision within 7 to 10 days if they're intubated, because this is what prolonged intubation will do. Trach by itself rarely can cause this to take place. Okay, so we kind of hit those 2 points. Let's move on to bronchial obstruction. So in bronchial obstruction, this is going to be a localized wheeze. We are not talking about all the bronchi. We're talking about bronchi that are affected in a local area. So let me give you an example. This is on the CAT scan, and you can see coming down the left main stem, there is an obstruction. If I'm going with the bronch, this is what I would see. Something in the actual endobronchial lesion. They can present in multiple ways. They can be completely filling up the lumen. They can be partially filling up the lumen. As a general pulmonologist who does a little intervention, this is as far as I would go. I would get a biopsy, and I would call it a day. Now, interventional pulmonologists can come and completely clean this airway out. They can cauterize it, they can cut it out, they can use cooling therapy. It's amazing, and the whole thing can be retrieved and taken out. But besides within the lumen, there are lots of things around the lumen that can cause problems too. So the entire lymph node system is impressive in the mediastinum and the hilar region. If you end up having histoplasmosis, which is very, very common in Tennessee and in areas around here, sarcoidosis, which is less common, or just reactive lymph nodes, the lymph node can swell to the point that it causes compression from the outside going in on the bronchi. You can see it on the bronch. You're going in, you're like, wow, there's almost like a flattening of the actual lumen as we're going inside. So, and also from malignancy. We unfortunately see this kind of late in the stage from lung cancer, which is why I also tell everyone to get lung cancer screening and do it effectively at their institution. So lymph nodes that are enlarged from whatever pathologic, reactive, can definitely cause localized wheezing and constriction of any of the bronchi airways. And you can see it basically in this photo that's going all the way from the trachea down the right main stem, left main stem, going to the hilar regions, anywhere. So this is what I was talking about earlier, how you can see where they go in with the bronch, and there's actually not quite a forcep, but another probe that they place in with the bronchoscope, and it can either heat up around the probe and basically cause the tumor to kind of break down, and then they take it out with chunks, or you can freeze it and take it out in chunks. And this is how the actual airway looked after removing the entire tumor. So it is impressive what interventional pulmonary is doing these days. So I'm going to just make a plug for that, because I think in the context of medicine moving to more non-invasive, though I love my thoracic surgery colleagues, it is an injustice to kind of not offer these kind of options to patients and say, hey, we don't have to make a huge cut. We can just go in with a bronchoscope and take it out. The other more, I think, amazing thing is they're doing interbronchial radiation, where they actually can place the wires directly at the tumor site and can radiate it. I mean, that's amazing. Besides doing external radiation, we can now do internal radiation. This is probably done in larger institutions, but it's highly effective. And these are for the tumors that you really cannot remove. There's a vascular bundle around it. They've tried removing it. They've cut down. It's just bled, and they're done. So this is options that are changing as medicine continues to advance. Now we're going to get to, I think, the crux of it. But I want to cover all the different types of obstruction so you have a good differential walking in when you see a patient wheezing. But for widespread airway obstruction, we're talking about now diffuse wheezing. These are the kind of pathologies and abnormalities or syndromes that you're more familiar with, that I think most people are more familiar with, myself included. So if we're talking about just kind of breaking it down, before we get to COPD, bronchiectasis is a very common entity, and usually it's caused by breakdown of the tissue leading to these dilated airways, and the mucus sits and pools in there. So this is an irreversible widening of small to medium airways. There's destruction of the bronchial walls due to inflammation. There's frequent colonizing, or frequent amount of bacteria that basically adhere to that of the wall and to the mucus there. It's usually caused by prior infections. It can be autoimmune. This is what we see in cystic fibrosis patients. Have diagnosed cystic fibrosis patients late in their 30s and their 40s who don't have a very severe form of cystic fibrosis as a child. Every time we get bronchiectasis, we do a thorough workup, because you never know actually what caused it. It's really hard to look at the airway and say, this is what this is. Alpha-1 antitrypsin deficiency, chemical exposure is very common. And these patients have a really hard time. They have really frequent relapses of severity and prognosis. I mean, the prognosis is not always that great either, unfortunately. The mucus just pools within the airways, and if they don't do really good CPT, cardiopulmonary therapy, they're kind of stuck. So if we kind of look at the CAT scan itself, you can see a variation that it can be anywhere from just a little bit of dilation of the airways in the left-hand part of the screen to extensive on the right-hand part. And this is there's a little bit of fibrosis here, but there's just a lot of bronchiectasis. So if we look at the causes, it can be, again, more localized, more diffuse. These are all the different entities that can cause it, but you want to just do a really good broad workup, because even if patients give you a great history, it sometimes misses what the actual cause is. So I just do a broad workup for bronchiectasis. I will check alpha-1 antitrypsin, and yes, it is undiagnosed an incredible amount of times, alpha-1 antitrypsin deficiency. And the fact that the fix is so amazing by just giving them back prolastin is impressive to me. So it is such an easy thing to do. Now it's just a swab on the inside of the cheek, right? And most companies will provide for a clinic sometimes for free, the actual test. So then you work great with the reps work amazingly well with you. And then now prolastin is no longer at the actual place to go get it at the infusion center. It is now being able to be done at homes, and you can travel with it. These things are changing as medicine's going along. Sputum culture, always check for kind of the non-typical bacterial, fungal, AFB, non-tuberculous mycobacterium is very prevalent in Tennessee, surprisingly. Cystic fibrosis, any kind of immune deficiency. Reflux is, I think, the enemy of the lungs. It just can cause everything, but it can definitely cause severe bronchiectasis. And then ABPA, allergic bronchopneumonia aspergillosis. There we go, get out. So basically for aspergillosis patients, these patients do not actually have a fungus itself that's causing issues. It is an overlying asthma, and over the asthma they have aspergillosis that really causes the asthma to continue to flare over and over and over again. You can find and diagnose ABPA, but you're really going to focus on the treatment for asthma. Sometimes they do require itraconazole for real treatment for that. So for going down the actual pathway of how do we approach bronchiectasis patients, these are the ones that exacerbate all the time. I mean, they're just constantly exacerbating. The mucus just pools in their airways, and unless they are able to cough it all up and to clear these airways, it is just going to colonize with bacteria over and over again. So the other option is macrolide. That's always a debate. Should we put these patients on suppression azithromycin, or should they get azithromycin as they get infections? You get 10 pulmonologists in room, 5 are going to say suppression, 5 are going to say treat as the infection comes. It's really hard to know. Azithromycin does have another great benefit as an antibiotic in the lung transplant world. It is used to prevent bronchiolitis obliterans, so it also has an effect on the immune system itself. That's really helpful. So that's the reason we debate with macrolide, should we use it or not. But this is where I think the beauty of pulmonary therapy comes in and respiratory therapy comes in, because the crux of this treatment is airway clearance and treating the underlying conditions. Hypertonic saline, mucomyst nebs, airway clearance devices, all the ones that we love. This is the ones you're going to take the time, teach the patients, go over it, nebulize twice a day. After you nebulize, use your acapella. After you do that, you can go ahead and use your inhaler. Use acapella anytime you want. Nebulizer over the inhalers. These are the things that will keep them from getting exacerbations. And despite all you do, they will still get it, but hopefully it'll be less and cause less hospitalizations. So that's bronchiectasis. Let's kind of go down the pathway to now looking at just bronchitis. And these are the things that urgent care is going to diagnose patients mostly with, right? Bronchitis. Acute is most common, usually from an infection, viral or bacterial. Most of the time patients recover, they do great within a few days or weeks. They usually don't even need to see anybody after that point. They have a little bit of wheezing, they don't feel great, goes away. Can become chronic, and that is if it's more than 3 months or more than 2 years in a row. This is where the airway lining stays inflamed, and there's more swelling and mucus production. Doesn't have to just be from an inciting virus or bacteria, it can be from something else. But these are the patients come back and say, you know, I had name whatever virus 2 months ago, and I'm still coughing, and I'm still wheezing. So why am I not getting better? This is where you do PFTs, and you say, hey, you have a little obstruction. I've never had asthma before. We're not saying you have asthma. We're just saying your airways are really reactive right now. They're really inflamed, so let's go ahead and temper that with nebulizers, inhalers, sometimes steroids itself. Prednisone can be your friend in that situation. Now we're going to get to reactive airway dysfunction syndrome, which can occur usually in some kind of exposure event. So this is a type of occupational asthma with a very sudden onset. These are your patients that come in and say, I was unpacking XYZ, or I was working with this chemical, or I was around a smoke or fire and I just could not breathe after that. And they cannot breathe to the point that they have to go to the emergency room. These are not people who feel a little bit bad. They cannot breathe. Unfortunately, it becomes lifelong damage in situations like that. So there is a high level exposure to a gas, a vapor, fume, smoke, you name it. They usually develop within 24 hours. Might not be right then. A few hours later, it gets worse. A few hours later, it gets a little bit worse. A few hours later, it gets really, really terrible. And they have this burning feeling, and that's, I think, the important point is when they say that. It burns in my throat. It burns in my nose. Well, that doesn't sound like asthma or COPD. I feel like there's been swelling. They will describe things. They'll be pointing to their entire pharynx, nasopharynx region, and they'll say, like, I just keep tearing up, like their entire body is almost under distress. This can be from exposure to anything, and everyone is different. Everyone's just going to have a different reaction. Floor sealants, spray paint, bleaching, household cleaners. This is why we never mix ammonia and chloride together and chlorine together. Chlorine by itself, sulfuric acid, hydrochloric acid, organic solvents, paint spraying, wielding, heating plastics, perfumes, silo dust molds, fire smoke inhalation. This is where we're thinking about the World Trade Center when it collapsed. Almost every single person there who was a first responder very likely had RADS at that point, besides a lot of other health deficiencies. Tear gas, locomotive exhaust, these are all the different things. It can sometimes be very innocuous. You try to go back, what were you exposed to that causing? You kind of go back in the pathway and you think, wow, that was a really mild thing that you're exposed to, but yet you're really in distress. So in these patients, I tell most of my primary care physician friends or family medicine friends, emergency room friends, do not waste time not giving them prednisone. Give them prednisone as soon as possible. Once the inflammation sets in and it persists, it can cause lifelong damage. It's done. The lungs are scarred. Not within the parenchyma, but within the actual airways. And then they really respond differently to inhalers. They are not your typical asthmatics or COPD patients in the sense they don't always respond. You keep giving them inhalers and they're just not doing great. So if you have anyone exposed to anything, find the cause, always treat the underlying poison control as your friend, always. And then treat them with prednisone, methylpred, prednisone. Don't waste time. Get them to a pulmonologist as soon as possible so they can do real PFTs. And they need the full PFT spectrum of this. So now we're going to kind of get to the crux of everything of what is actually COPD. So COPD is a chronic airflow limitation due to two things: chronic bronchitis and emphysema. This is the actual definition of it. If we break down chronic bronchitis, it is defined clinically. It is a chronic productive cough over 3 consecutive months for 2 consecutive years. You also have to have some kind of pathological with this. Usually it's emphysema with an enlargement of air spaces, distal to terminal bronchioles, destruction of the air spaces, and no obvious fibrosis. This is the technical ATS chest definition of COPD. I think it's used a lot for a lot of different things. So if we look at kind of the pathway of this, if we look at cigarette smoking at the top, or biomass burning, smoke inhalation, any form can cause COPD. I'm not going to go through the whole slide, but it basically, I wanted to highlight the amount of physiology that takes place when that occurs. There's a pathway that gets basically in action. It gets set, and from that point on, there's cytokines that come in, inflammatory markers, oxidative stress. This occurs over years and years every time you smoke. This is what's happening. And then it leads to small airway fibrosis, emphysema, and mucus hypersecretion. This is why COPD is so hard to treat, because we're working with an entire cascade of cytokines and inflammatory cells that come into the airways every single time they're exposed to that kind of smoke or inhalation. And every time they stop, the lungs start to heal just a little bit. And every time they smoke, again, the same thing occurs. So these are healthy lungs on the left-hand side. You can see the bronchiole, the alveoli, they're all very open, everything's very calm. The airway lumen is nice and open. On the right-hand side of COPD, where the alveoli become destroyed, there's an influx of mucus, there's narrow bronchioles, and this leads to the airways, as you can see in the bottom right, becoming really thickened with mucus, with the walls themselves becoming destroyed, and then all the influx of cells that occur. So if we are trying to classify COPD, there are 2 scales that we can use. There never is really like a head-to-head trial saying one is better than the other. They're used pretty much symbiotically, used together every time patients come in. So there's the modified MRC dyspnea scale and the COPD assessment test. This is similar to what you see for sleep apnea patients and when you're doing their actual every time they come back for the annual tests or the annual clinical exam, you're doing all their scales also to see where they are with their sleep situation. Similar. I don't think everyone does this for COPD, but it's really helpful because you get an assessment really of where patients are at. Number 1, like I only get breathless with strenuous exercises 0 all the way to 4. I'm too breathless to leave the house. And this gives you something to actually hang your hat on because patients will just say, well, I'm short of breath. Okay, well, where is short of breath? Can you walk to the bathroom? No, I can't walk to the bathroom. Can you put your clothes? No, I can't put my clothes on. So this kind of gives us some kind of objective numbers to look at also. The COPD assessment test, I think, is actually really helpful because it doesn't just talk about dyspnea. It also talks about cough itself. I never cough, or I cough all the time, or I have phlegm. I sleep, I don't sleep. I am short of breath going up a hill. I'm not short of breath going up a hill at all. So all of these, I think, are really helpful to really get a sense of where your patients are at. So once you know this is COPD, you've confirmed it, you've done your PFTs, you've had your testing, now you've done all of your assessment of their clinical status, then you say, okay, well, how am I going to treat you? So this is the goal criteria. The goal criteria recently just changed this, which I'm going to go over. The focus used to be on the, if you can see on the left-hand side, this is looking at exacerbations, how often they have it, 1 or 0, 1, or greater than 2, from the last time you saw them. And the 2 scales I was talking about are at the bottom, the M modified MRC or the CAT. So based on where patients are, I exacerbate a lot, but I don't really have a lot of symptoms. You're still going to treat them probably with a LAMA at that point. Or exacerbate a lot, but my symptomology is actually pretty good. Then you're going to focus probably on long-acting bronchodilator. They just recently changed this and came with a new criteria. They kind of got rid of C and D, and they just work with group E. So now the focus is really on exacerbations. That's great that you're able to go hiking up the Smoky Mountains without any problem. When was the last time you were in the hospital? Yesterday. When was the last time you were in the hospital before that? Or seeing your primary care doctor or whomever 2 weeks ago? We have a problem because you're exacerbating way more often than you should be at this point. So for those patients that are saying identify them early and then go ahead and treat them with a combination inhaler, a LABA/LAMA, or a LABA/LAMA with an ICS if their eosinophils are greater than 300. I think this is important because we used to kind of do this very sequential pattern with COPD that we used to do with asthma, which is still there for step therapy for asthma, where you say, let's try the short acting. Okay, it's not working. Let's try the ICS with the LABA. Okay, that's not working. Let's try. And we just kind of kept trying and trying and trying. And then we would see them back like every 3 months and just add one more inhaler and one more inhaler. And now the data is coming back and saying, don't do that. Like, don't waste time. Go ahead and give them a strong combination inhaler from the get-go if they are if they're having a lot of symptoms and they're exacerbating a lot. The guidelines have changed with just saying don't just do one, do a combination inhaler. So asthma is an entire presentation all to itself, which I'm not going to go into because you guys would be here for way too long with me. But if we're talking about asthma versus COPD, the difference is there are some. It is a little bit more complicated as patients get older. Myself, when I see that they're asthmatics when they were a kid, now their asthma's changed and they're an adult. They smoke also, and they have been smoking. Do you really have asthma? Do you have COPD? And I'm going to tell you why people are saying it doesn't matter in just a minute. So with asthma, usually it's a childhood manifestation, right? COPD can occur usually later in the years after some kind of trauma to the lungs from either smoke inhalation from cigarette smoking or your work exposure. For asthma, it's nice to kind of ask about allergies because they will point to it. They'll say, oh yeah, it's really worse in the fall when this happens or in the spring when that happens. And COPD you'll find from cigarette consumption. Asthma, they're pretty stable, and then they just have these bursts. And then COPD, they just get worse and worse. With asthma, there's really not much of a cough. It's not really, if it is, it's not really productive. It can be when they're having exacerbation, but at baseline, it doesn't really exist so much because their airways are really normal when they're not having any asthma. With COPD, it's just cough that's all the time. With asthma, they can have these changes throughout the day. In the morning time, they might be fantastic. By nighttime, they're terrible. With COPD, they're either great all day long or they're terrible all day long. With asthma, they can wake up, and that's usually kind of your clue. They're like, I wake up and I'm short of breath. I wake up and I'm coughing a lot. Oh, okay, well, that's when I see COPD patients, they're just going to be coughing all the time. And usually when they go to sleep, they're not doing any actual exertional activity. So they don't cough that much unless they're having exacerbation. And then check for any kind of seasonal allergies or atopic symptoms. If they come back and say, yeah, I have a lot of eczema, then you're probably in that entire allergic profile where you have some kind of atopic problem or atopic syndrome within your immune system itself. And then if you're looking at the actual PFTs, it's reversible with asthma and it's not reversible with COPD. Now, that changes. With asthma that patients have had for years, and they have had recurrent exacerbations, yes, their airways can become fixed. you still really focus on the allergic component of it because they're still having an influx of cells that are different than COPD. But now, asthma and COPD are considered more on a spectrum. It used to be, do not give the COPD patients inhaled corticosteroids. Do not give the asthmatics anticholinergics. That has really been shifted. It has become kind of a gray world where you might do really well with anticholinergic, and we used to use, man, I remember when I was a resident fellow, if I ever gave an anticholinergic to a patient with an asthma exacerbation in the hospital, my attendings would basically show me the trials and then hammer me never do that again. And I would put that in my note. That's changed. I mean, it used to be just albuterol asthmatics. Now it's duonebs. And the data is coming back and saying there is really almost a spectrum between asthma and COPD. It's not very clear cut that this is asthma and this is COPD. So really tailor it to your patients, the type of approach that you have to them. I know we're all familiar with this chart. It's one of my favorite things to see in a room. But if we kind of break it down into the different types of inhalers, I'm not going to go over in great detail. The short-acting beta agonists are the ones you're familiar with: albuterol, ProAir, Proventil, Ventolin, Xopenex. And then you're going to have your long-acting beta agonists, which are Perforomist, Brovana, those are your nebs, Ceravent. Have you guys noticed this year how hard it was to get albuterol for patients? It has been weirdly challenging. Most insurance companies have been asking for a prior authorization, and I'm like, I'm so confused. It's albuterol. It should be available at grocery stores as far as I'm concerned, over the counter. But Xopenex has been easier to get. So I'm curious to see what happens going to 2025 as insurance companies go through their formularies again and kind of basically decide what's important, what's not. The one you really cannot give by itself ever, though the rules are changing, the one cardinal sin is you cannot give an asthmatic a long-acting beta agonist by itself. You cannot give Ceravent by itself. There have been study after study showing that it is terrible for the asthma and it can lead to increased mortality. So there are a lot of providers who should know this, but yet they don't. I've had patients come to my office and they're like, I just take Ceravent. And I'm like, and? Like, in just Ceravent, I'm like, and? This is the only thing you take, you're an asthmatic. This is not going to work. This is why you're exacerbating. So it's the one thing you cannot just give by itself for an asthmatic. For COPD patients, very different. If we kind of break it any more into inhaled corticosteroids, you guys can see kind of the usual suspects here. I think each one has its benefit. Every patient is very different. Some like one versus the other. Some do well with one versus the other. So I don't think there's one that's really standing out. I'm always a little bit more of an aerosolized girl than a dry powder girl, but that's kind of where I've seen my patients do well. And then muscarinic antagonists or anticholinergics. You're looking at Atrovent, Incruz. These are, again, your inhalers. Pressair is kind of interesting. That's the ones as Tudorsa. Some of my patients really, really love it. I'm really confused by that because I think it's kind of hard to use, but they really love it. And then if you want the nebulized form, that's Upellary, which, by the way, is a lot easier to get than it used to be. And I think my COPD patients do extremely well with Upellary. One nebulizer once a day. They love it. They do great. And then don't discount your PDE4 inhibitors. These are the ones that help your inhalers do better, and that's Dalaresp. There is a new product on the market. It is available. It's an inhaled PDE4 inhibitor, and it's highly effective. It reduces exacerbations by 30%, but it's really hard to get. It is a challenge to go through all the hurdles to get it. So I think that's going to be really exciting to see where that kind of falls into the COPD world, where we've done the full triple inhaler, we've done nebulizers, we've done CPT, and now we have nothing else to give. This is the next thing to give. The combination ones, Breyna, the one in the left-hand corner, is just generic Symbicort. That's all that is. Same stuff, just a different label on it. Wixella is still your cheapest one to go to, $45 without insurance. Still the cheapest one there. So there are some things that are affordable a little bit. And then you're looking at your combination ones, your long-acting LABA and LAMA, Vespi, and then your triples, Trelegy, Breztri, your combo ones. So these are the biologics that we're not going to touch on in great detail, but there is a new exciting thing that's available with it, so I want to touch on that. And then you look at trying modifiers like Singular. which can actually be helpful to patients with COPD because sometimes they have that asthma COPD overlap, and Singulair is highly effective with asthmatics. So if we're talking about biologics, we're talking about injections that basically work at a cellular level and the entire kind of cascade that we were talking about earlier. There are a lot of biologics available for asthma right now. Xolair is the oldie but the goodie. But this one has one huge downside. Do y'all know the kind of problem with Xolair? Why you have to give it in the office, why they can't take it at home. I love this part about Xolair. It can cause massive amount of bronchoconstriction. Yes, you're giving it to patients for their bronchoconstriction and for their asthma. But they can end up having such a traumatic level of bronchoconstriction from the Xolair that they have to have an EpiPen. And that's what has to be administered in the clinic. So we have fallen away from Xolair, but it still works great in the allergy world for like hives and other deficiencies. It don't completely throw it away, but it's really not what we're looking for. We're looking for COPD asthma patients. Then there's Nucala and Fasenra. These two are looking at just eosinophil counts to kind of get qualified. Then we're looking at Synquair, which nobody does. Nobody does because it's an infusion IV bag. No one's going to do that in anyone's clinic or in the hospital. It's just not going to happen. So I'm surprised Synquair is still in the market or trying to stay in the market. And I think they're going to probably work on making theirs inhaled. I feel like they're moving to something different, but we'll see. And then Dupixent and then Tezspire. So Dupixent is important because it is now approved for COPD. We now have biologics in the COPD world, just confirmed by the FDA. This is a maintenance add-on to maintenance therapy of patients who are not having good control. None of the biologics are solo therapy. They are not the only medicine patients can take. I have patients who have done so terrible with asthma over the years, and we start with the short-acting beta agonist, add the triple inhaler, we add nebulizers, we probably do some prednisone if we need to, and we start them on biologics, and this takes time. These biologics takes 3 to 6 months to really have a full effect, but they'll come back. They're clearly doing well because they're not seeing me for follow-up. They're coming back like in 4 to 6 months, like, I feel great, I stopped everything. And I was like, what's everything? And they're like, everything. And I was like, what about your shots? Are you still doing those? Yeah, I'm just doing those. No, my friend. This is maintenance therapy. That's an add-on. This is not solo therapy. I think eventually we will get to this being solo therapy, but it's not there yet. The trials have not been done in that way. That's the reason no one can come forward and say, yes, you can just use Dupixent. So the trial was just done, and this was the NOTICE trial. And they did the second of 2 phase 3 studies, and it achieved its primary objective very quickly. And it reduced exacerbations in moderate to severe COPD patients by 34%. That's huge. That is huge. So now COPD is changing. It is no longer, you cannot use inhaled corticosteroids. Yes, you can. You cannot use Singulair. Yes, you can. You cannot use biologics. Yes, you can. And now that Dupixent has opened that door, I guarantee all the other companies are going to come right behind it. No doubt about it. I think this is going to change our level of COPD exacerbations dramatically. And I'm looking forward to that. Because my asthmatics are great, right? They feel terrible. I give them stuff. They feel better. My COPD patients are never better. They're always struggling. So I'm really excited about this being available. And now that we're familiar with Dupixent, we've been using it for a couple of years now with asthmatics, we're going to be fine with the COPD ones. The only difference is you have to confirm with the pharma group that makes it, that the eosinophil count is high. I still think it's going to be a challenge. These patients with COPD are really on prednisone a lot. They exacerbate quite a bit. So how are you going to confirm that the EOs are greater than 300 if you're giving the prednisone, you're bringing the entire white count down, including eosinophils? That, I think, is going to be the challenge. I think you're going to have to find the angle if they're an asthma COPD overlap. I'm going to kind of treat both and see if it works that way. But I'm really excited to see how this is happening. I don't think it's available yet for prescription for COPD, but I'm sure it's coming for 2025. This has been in the books for a while. And then one of my favorite things to use is acapella, which I'm sure you all know and love. I also think it's amazing how difficult, I'm not sure if you're all aware of this or not, how amazingly difficult it is to get acapella in the outpatient world. It is such a challenge. So if your patients are in the emergency room or in the hospital and you are called to see them, please give them the acapella. Please give it to them then. because it is so hard to get them outpatient. Sometimes we just try and we try and we try, and I'm finally like, just go on Amazon, order for $40. Like, I don't know what to tell you. I can't get you a real acapella. And they don't want to spend the $250 or whatever price they're getting that's astronomical. I love the fact that there's different versions of acapella, right? You can dial it up, dial it down. And then, are you all familiar using the acapella that goes right through the nebulizer? I love that one. That one's amazing too. And I just went to Chest, just met with the company that makes acapellas, and their products are shifting too. Like all the different acapellas that you're seeing, the different colors, they're making those available for nebulizers. They're shifting theirs also. So I think acapellas are an underused tool that is such a simple fix. You're creating such great mucus clearance with these patients with any level, and it can be done all the time, anytime. But I really think it benefits the most after you nebulize. Nebulize, really your duonebs, your albuterol, your Zopanex, whatever you're doing, and then use acapella, clear all the mucus, and then inhale all your inhalers that you've got. The other non-pharmacological therapies that exist are in the emphysema world, which has been here for a while. Not everyone's doing it because it's got its risk. Basically, you're putting a Zypher valve. So if we're looking at the bottom left corner here of the right upper lobe, left upper lobe for the emphysema, let's say in that left bottom corner, that right upper lobe is useless. The emphysema is so terrible. There's blebs, there's bullae. It is doing nothing to help us. In fact, it is hurting us because now our VQ mismatch has worsened. So they are on 5 liters of oxygen. They keep exacerbating. We have these huge blebs and bullae just in the right upper lobe. We can put in a valve that literally goes all the way up to that bronchi leading to the right upper lobe. Place that valve, and the valve basically closes up. As it closes up, it deflates that part of the lung. So the right upper lobe is now out of action. It's no longer participating in inspiration and exhalation. So now your VQ mismatch improves and your oxygenation improves. This is really for select patients. You have to have a localized bleb or a localized bullae, or has to be localized emphysema in one part of the lung. It cannot be all over. But the problem that occurs is that the risk of placing these Zypher valves, that's the reason it's only done so far that I've been known at Vanderbilt. The interventional pulmonologist at Vanderbilt just moved to Ascension, so I'm pretty sure they're going to be doing it Ascension soon. Yeah, go ahead. Yes, UT, for sure. I was thinking more than Nashville World. I think like larger centers is usually an interventional pulmonologist. And the reason is the risk of pneumothorax is 30%. Not in the lung that you put the valve in, the other lung. Because now it's working extra hard. It wasn't working extra hard before. It was kind of just trucking along with the other lung. But now it's working extra hard, so it's a 3% risk of pneumothorax. So these patients get admitted to the hospital, they get the valve placed in, and then they're monitored for 24 to 48 hours. It is highly effective, though. If you find the right group of patients, you will see their oxygen improve the next. We're back. Okay, cool. You will see their oxygen improve the next day. They will be on 5 liters, and they're on 3. I mean, they never really cut off oxygen, but they're more functional. They feel great. Once these valves are in, they're in. They usually don't move. Stents can shift and move around, but these valves that are placed in, they're like wedged right in that airway. They're not moving. So it can be really effective. And then one of my more favorite things that I try to get all my patients to do for any type of airway obstruction is pulmonary rehab, which is where you guys come in. And I try really hard because there's only 2 things in the pulmonary literature that improve FEV1. Only 2. Quitting smoking and pulmonary rehab. Everything else maintains it. If you do not have asthma and you have bronchiectasis, chronic bronchitis, COPD, RADS, all of it, there's only one thing that makes FEV1 better, and that is quitting smoking and pulmonary rehab. So stop smoke and exercise more. But exercise in an actual place where there are therapists who will guide you down the right pathway of what you need to do. I have patients who are like, oh, I tried pulmonary rehab and it didn't really work that great the first time. And I'm like, well, you know, it is just exercising. Why don't we try it again? And they'll try and they'll come back and they'll be like, this really helped this time. You know, I'm going to keep going once a week, or I'm going to keep going once every other week. All insurance companies will cover pulmonary rehab. Every single Medicare, Medicaid, all of them. There's a waiting list to get patients in, and it is a commitment to them, right? They have to drive to this place that is providing it for them. It is 2 to 3 times a week. It is a couple of hours each time. A lot of patients say, I just can't drive. I can't make that happen every time. Wish we had like a ride share, and there are some places that do set it up, which I think is amazing. But it's highly effective. There is some pulmonary rehab you can do at home also. I think, especially during the pandemic, it was amazing. I don't know if y'all saw, there was one of the respiratory therapists in New York that really early in the pandemic started having videos that were sent out about what you can do for pulmonary exercises. It was amazing. It was highly effective. I actually gave that URL to all my patients early on in the pandemic because I was like, this person's telling you how to do this at home and how you can do this safely. So that's my little plug for pulmonary rehab. The patients who come back in to the emergency room, who are coming in the clinic over and over again, getting hospitalized over and over again, please give them a brochure about pulmonary rehab. It's on ATS. You can print it out. Your institution might have it. You can give them the pamphlet. It is highly effective. These patients I have never had a patient go to pulmonary rehab and get worse. If anything, they feel like they've maintained, like it never really helped me. But yeah, but now you're on 3 liters of oxygen, you were on 4. Well, I mean, 3 is better than 4. I mean, we're moving in the right direction, so I'll take it. Or they're not exacerbating as much. So I think it's really important. So in the context of kind of airway obstruction and more widespread airway obstruction, please give pulmonary rehab about how effective it can be. And with that, coming up pretty soon, November 20th, is actually Know Your Lung Function and COPD Day. So that's pretty much my talk, and thank you all for being so attentive. I appreciate it. Any questions? Yeah, please. So the question is for RADS, or reactive airway dysfunction syndrome. How often I send for a methicillin challenge test? I have sent patients for methicillin challenge tests even just for asthma itself. So I think it can be highly effective, yes. It's hard in the initial stages, right? Because when they're seeing you or they're coming in to see you, it's either one of two things. They're coming to see you really early when they're still exacerbating and you have an opportunity to give them prednisone, or they have come in too late. Like they've come in and it's already, the damage has been done, and they're like, I never got better after I got exposed to that chlorine, whatever, like spill that occurred. So I do try to do it for them. I think people have gone away from methicillin challenge tests over the years. It's a little more challenging to do in institutions. I mean, I was a Stonecrest, now I'm at Centennial. I love Stonecrest and Smyrna. We did have methicillin challenge. We were the ones that enacted it. My respiratory therapist would be like, are you ever going to send us one? Are we ever going to get a patient to do this? I'm like, we're working on it. We're just trying to find the right group, but it becomes a big deal. In bigger institutions, it's more available. But I do think it has great benefit. Mm-hmm. So the question is, if it comes back negative, methicillin challenge test, do we still treat them the same? It's hard to know. I'm not going to lie to you. I really go back to really history and the inciting event. And most patients will tell you, right, it happened this day. Like I was fine the day before, and then this day I was not. So that's it. It's just a history. The challenge, I think, becomes is if you don't see a physician, this is from something in your occupation, you're never going to get that disability. Like it doesn't happen. So that's the reason I tell any of my providers, if they, early on, if they have a patient with primary care physician, family medicine doctor, or the emergency room, if you think this is RAD, send them to me early, because then we can confirm that it is. If they see me too late, I have had patients who we tried, we just never got disability, because you need to have the inciting event. You need to have documentation of it. You need to have documentation of the PFT, methicillin challenge, all of it. And they don't want to do any of it because they feel terrible, but it's highly effective. So, yeah, I've had patients who couldn't go back to work, and we couldn't do much about it. So it's important to treat it hard. Good questions. Anybody else? All right. Well, then thank you for your time. I hope you all learned something.